and good morning, depending on where you are in the country. Uh, we're really excited to have this collaborative primary care spinal cord injury network kickoff meeting. If that's what, hopefully that's what you were expecting. So maybe what we'll do is just do a little go around and introduce ourselves as to who we are. Maybe just to help facilitate, I'll just use my screen and call out names, and we can go around. So I'm Joe Lee. I'm a family doc in Kitchener-Waterloo, Ontario. I chair our local Ontario health team, as well as I'm primary care lead for this region. And work with the Center for Family Medicine Mobility Clinic team. Lindsay?
Hi, I'm Lindsay Byerman. I am the Research and Evaluation Manager at the Center for Family Medicine, and a lot of my work is with Joe and Jamie in the Mobility Clinic.
She puts up with a lot. And so, Steve?
Hi, my name is Steve Boyson. I'm here in Kitchener. I have a spinal cord injury, and I've been with the Mobility Clinic, I think, since 2015.
That's great, Steve. Thanks. Patricia?
Hi, I'm Patricia Nestor. I'm a research assistant with the Center for Family Medicine, and I work mostly with the Mobility Clinic.
Great, Patricia, and a shout out for her for doing a lot of the prep work for this event. Chester?
Hi, I'm Chester Ho. I'm a physiatrist in Edmonton, Alberta. And one of the reasons why I'm interested in this is because I have a project and an interest in how to really integrate the care of people with SCI along the continuum of care. And of course, primary care is a critical component of that. And so it's really my big interest to see how we could work together to engage our primary care partners in the community in the care of people with spinal cord injury.
That's fantastic, and we're excited you're here, Chester.
Thank you.
Charlene?
Hi, good morning, everyone. I'm Charlene Youssefi. I'm the Knowledge Exchange Lead at Praxis Spinal Cord Institute, joining today from Vancouver, very rainy Vancouver. Thanks for having me today. My role and area of interest is really around how we can support the Praxis continuous strengthening of networks across Canada, as well as sharing and knowledge exchange within and across networks. So I'm very pleased to be here today, and thanks for having me.
That's great. Thank you, Charlene. Ruchi?
Hi, everyone. I'm Ruchi Parikh. I'm a research assistant at the Center for Family Medicine, and I work with the Mobility Clinic.
Thanks, Ruchi. Jamie?
Hi, everyone. Thanks for coming. I'm Jamie Milligan. I know all of you. So I'm a family physician in Kitchener and work as the director of the Mobility Clinic.
Great. Tori?
Hi, my name's Tori Bowman. I work with Peter Athanasopoulos at Spinal Cord Injury Ontario. I wear two hats at SCIO. I'm the Director of Knowledge Exchange and the Managing Director of CoreTree, which is a social venture we launched last year. And I kind of invited myself to this meeting today. I hope that's okay. I was talking to Peter last week. We have done a number of different knowledge exchange activities and products over the years, some with Joe and Jamie on primary care. And we were thinking, what can we do this year? And Peter suggested that joining in, or at least listening in today, would be a good way to get a sense of where this group is planning to go. So thanks for having me.
And if we get more people to invite themselves like you, Tori, we would just be completely fine. That's fantastic for joining. Thank you. Vanessa?
Hello, everyone. I'm Vanessa Noonan. I work at the Praxis Spinal Cord Institute with Charlene. And as Charlene mentioned, we're very excited to be able to support this work and see how we can also help in the spread of development of primary care models across Canada. So super excited to be here today and see how we can invite more people to these meetings as well.
Yeah, thank you. We're equally excited, Vanessa. And Tara?
My name is Tara Jeji. I'm the Program Director for Spinal Cord Injury Research and Implementation Program at Ontario Neurotrauma Foundation. So we have been working with Joe and Jamie in developing their work, especially around mobility clinics and initiatives for more than a decade. So I'm here to support them and hopefully we can have a better primary care for Ontario.
Thank you, Tara. John? Okay.
Oh, hi. Sorry, guys. I'm full disclosure. I'm actually juggling two separate calls, so I really apologize for that. Anyway, I'm a graduate student studying health services research, and really interested in trying to bring some data to what happens to people with spinal cord injury after disc. And I've worked with a primary care database recently. So yeah, I do apologize. I know it's bad manners to be double booked, but anyway, you will have my audit attention at the end of the half.
Thanks, John. And don't worry, I think we all understand about multitasking these days. So thank you for joining us. Peter?
Hi, everyone. I'm the Director of Public Policy at Spinal Cord Injury Ontario, as well as the Executive Director of the Ontario SCI Alliance. The Ontario SCI Alliance has a keen interest in this work and moving forward in pathways that can support our community in primary care. We've worked with Joe and Jamie in the inception of developing the first mobility clinic and keen interest in expanding mobility clinic across the province in a variety of different models. And I'm just delighted to work with this team and to look at strategies and how we can create a better experience for people accessing healthcare in the community.
Great, Peter. We're always excited to have you join us and also for you to bodyguard Jamie. So I'm going to share my screen now, or at least try to. Can people see the slides?
Yeah.
Okay, great. So, oops. Okay. So yes, this is the primary care SCI network meeting. We want to really start off by acknowledging people with lived experience who really are integral to the work that we do, and really value their input. And why we are going to lead off soon with a story from Steve to help ground us with the work that we do. We also want to acknowledge the not just the financial support, but really the support in so many ways, collaboration, resourcing, so much support from Praxis and ONF from your organizations. So thank you very much. The agenda for today, well, we've done the introductions. We're going to have Steve tell us a personal story. Jamie is going to review some of the primary care work done to date. And then we're going to discuss the network and steering committee terms of reference, take a break, have more facilitated discussion afterwards, and then wrap up. I don't know if there's any any questions or comments, suggestions about the agenda. Okay, assuming I'm not on mute or frozen, I'm going to take it as no, and maybe I'll just get Jamie to introduce Steve. if you don't mind there, Jamie.
Yeah, thanks, Joe. So, yeah, I mean, this, so when we send out invitations to this kickoff meeting, we try to keep it as a smaller group. I'm just going to start off by sort of saying that this is a group that we're sort of handpicked to sort of help us determine how we develop this network and do it in a proper way. In the last number of years, we've had, oh, hi, Colleen. I just saw that you joined there.
Yes, actually, maybe I'm going to interrupt that. And we've done some introductions. I should also have mentioned something that Lindsay told us, and both Jamie and I forgot. We are recording this, FYI. So with that, Colleen, did you want to introduce yourself?
Sure. Hi, I'm Colleen O'Connell. I'm a rehab doc, kind of like Chester, over on the East Coast. Originally, I had a full solid clinic booked for today, but we had a case test positive that visited our building, so we're shut down. So I could actually attend now.
Yay, COVID-19.
Well, thanks so much, Colleen. It's great to have you as a part.
Thanks.
So I was just sort of saying how this has kind of come about, and then I'll introduce Steve there. So really, we've kind of had an informal network, I think maybe for the last 10 years or so, that's sort of built up. You know, a lot of collaborations with various people at different times. You know, but what's been sort of determined in the last little while is we need to sort of formalize something, and this would help with, you know, a number of agendas, both clinically and both from a research perspective, you know, with the ultimate goal, as we mentioned right off the top, of really improving care for individuals with spinal cord injury, primary and community care. So that's really where this comes from. So we have sort of a large network of which, you know, have developed out of some of the summits we've done, and we've done some webinars that many of you guys are probably aware of. But then we sort of asked a few people to come together to sort of help us today to understand how we move this network forward in a meaningful way and a viable way. So that's why you were hand chosen. And there was a number of other people who have been chosen who just couldn't attend today. Just, you know, it's hard to schedule these things. So that's kind of the background of things. Now, we have had a number of people with lived experience that have been a part of the clinic. We've had an SCI advisory committee for a number of years, and we had invited a few of our persons with lived experience out today, and some of them were not able to make it due to scheduling, but will be involved further on. But Steve Voisin, who's on our Zoom conference here today, was one that we invited that has agreed to participate. And although we probably don't need necessarily a personal story per se with this group, because they're all quite aware of many of the issues, we still felt it's important to have a bit of a personal story to sort of bring this all back, you know, set the stage, ground us, and really understand why we're doing what we're doing. So Steve was kind enough to share his story with us for the next, you know, few minutes. And so with that, Steve, maybe I'll pass it over to you just to talk a little bit about your story and your journey.
Well, thank you, Jamie. Everybody can hear me now? Yes?
Yeah.
Oh, okay, good. Well, my story started the summer of 2008, where I would stagger and stumble, and I couldn't keep my balance, and friends would think that I was drinking a little too much, but they all know that I don't drink. So I approached Dr. Lee, and you know, we did some tests and didn't really find anything. So March of the following year, I went back again, and at that point, he did some more tests. He asked for a CT scan, and he sent me to a neurologist. And the neurologist, you know, did the EMG, and the bottom line was I did have some trouble. So he sent me to MRI, and all this took a lot of time. Like, and that was that was one of the issues that I had at the time, but I guess with, with today's money factor, can't have an MRI the next day like we like to. So by the time everything was said and done, I had my surgery in October with a local doctor here, local surgeon, Dr. Mormer, and it went well. I was able, at the end of it, came out flying colors. I could walk again, or I could walk. And that was good for 5 years. 2014, I started having trouble again. Again, went to Dr. Lee. Again, had to go through the CT and blood work and urologists and where am I? Yeah, and again, all said and done, Dr. Mormer wasn't available anymore. He left Kitchener to do research in Europe. So I had to go to Hamilton with a Dr. Reddy, and he was just gonna drill a hole in my back, or he did, drill a hole in my back, insert a 1/2-inch tube in that hole and did the surgery like in that tube. It's hard to believe, but that's what happened. And at the end of it, I felt awesome. I thought I could run again. I could walk. Like it was amazing how well I could get along, and I was so happy until 6 weeks later. It all went back to pain and normal, couldn't walk, or I could walk with a cane. So that was some sad news. So again, I needed, I guess, more surgery. So Dr. Lee again, we went to the neurologist and we talked to Dr. Reddy in Hamilton, and he wasn't very responsive, but finally he did respond, and he wanted me, because apparently he didn't do the whole back surgery. He just did, I think that was his specialty, with the whole surgery. So he said his associate would help, and his associate though was going to be a long time out. And Dr. Lee tried to shorten that, and that didn't work. And I got worse. And basically Dr. Lee said, like I was having trouble urinating. And he said, if it comes to not urinating, you got to call me. And so that happened in August, August of 15, I think it was. 14, 15. And that's when basically I woke up one morning and I couldn't walk. Like I was using canes, but I woke up that one morning. So we went in to see Dr. Lee again, and that's when he said that if you don't urinate, let me know, because he was concerned. So that happened, and we went to Emerge and in Kitchener, and he had, I believe he, he told the Emerge about me, and because they were ready, and they did some tests and basically said, yes, you need to go to Hamilton. So I stayed in the hospital for about a week until Hamilton Rehab or Hamilton General was ready for me. So I got to Hamilton General, and I waited another probably a week until a Dr. Bedner saw me, and he was a neurosurgeon, orthopedic surgeon, and he was a very nice guy. Well, just like the mobility team and the Dr. Lee's team, they're all good people. I had some trouble with Dr. Reddy, but Dr. Bettner was totally good. So I had my surgery in Hamilton in October 15. And then I stayed in rehab in Hamilton. They have a very, very good rehab center. Their physiotherapists and OTs are totally awesome. I really felt I was in rehab heaven. Like, people were so nice. They knew exactly what my issues were, like stuff that they had to go through because of being after surgery, of, not being able to urinate properly or go to the bathroom properly. They had to do so many things to get me through the day. It was unbelievable. So anyway, I was there for 10 weeks. And I couldn't walk after surgery. Like, I could not walk, but I was gonna walk. Like, every day I would work very hard. And by the time 10 weeks were up, I could almost walk with my walker. I wasn't good at it, but I could walk. I got a new walker and I got a wheelchair when I left the hospital. So I just worked again. My employer at the time I started, he was good for me to take off time. And then when I come back, I would walk out in their shop every day for an hour at the end of the day. And he was good that way for me to help me get strong, to start walking. And in a few weeks, I started walking pretty good. And that was when I was introduced, like after I got out of rehab. It wasn't long before I was then introduced to mobility clinic, and I met Jamie. And since then, we've been doing, like at the beginning, we were doing 6-month checkups, just to see how I was doing. And then later on, it was 1 year. Now it's 1 year. We just, how you doing? And he does some tests and just sees if I'm getting worse or how I'm doing. So that's good to hear. And the other thing the mobility clinic has included me in on some projects. I met a doctor from Sioux Lookout. I don't remember her name, but she was looking, I think, to set up some type of same situation as a mobility clinic up in her area. And she was also trying to reach out to her patients with Zoom or Skype, but it wasn't Zoom or Skype. It was something through the Ontario Health, and that was another project that I was included in with the mobility clinic, that type of thing. But boy, it was archaic. Like, it was awful. Like, you couldn't use Google. I don't think you could use Explorer. Like, I don't know what we used, but we finally figured it out, and we did do some Skyping, and it wasn't like today. So the mobility clinic has done well for me. Yeah. So these days, I want to stay. Like 3 years ago, it's 4 years ago now, I was in a 4-level house, and it just got to the point where I had 4 walkers, one on each level, and it was just not working. So my son said, "Dad, you got to move somewhere where it's all on one level." So it was just a godspell that the paper landed a day, 2000. Oh, anyway, 4 years ago, whatever that is, 16, I guess. And the condo is uptown Waterloo, and I always wanted to live uptown or downtown. So this place came up pre-construction, so I bought a place, and last year I moved in. Well, it's a barrier-free unit, but the only thing I can do is it's got the 5-foot circle in the entrance and a 5-foot circle in the bathroom, but I can barely get in my bedroom and I can barely use my living room and kitchen. So to me, the barrier-free limits or the barrier-free limits have got to change for people in wheelchairs. The other thing I did, and I installed an auto door opener, because getting in and out the door with groceries and whatever was ridiculous. I just, and the other thing I've done, and started to do, what I did was I researched automatic cupboards. Like I hated all this wasted space that I couldn't get to. So I researched automatic cupboards, and it happened at a family Christmas dinner last year that my daughter-in-law, well, my son-in-law's partner, her brother is Jeff Kerr, and he's a big real estate guy in Toronto, and he is he's approaching builders to think about roughing in or think about people with wheelchairs and people that can't reach, like elderly people, and so we want elderly people to stay in their homes, in their communities. And that's what I want. So he introduced me to Yves Trache, who is with Simple Freedom Design. And what he does, he installs automatic cupboards. So now I can just push a button and a cupboards, upper kitchen cupboards, closets, they come down to counter height. So I can reach everything on, so my usable space is more. So that to me is what my kind of goal is, to help and to put it out there that the government rules have to change. They have, like I researched in Australia, what they do in Australia is contractors, they have to rough in from the get-go ways of people can renovate in the future to make the homes or whatever easier for seniors to come into, people with disabilities to come into. So that's what my gift is to this collaboration. Anyways, Steve Oyson is out. I should mention that the mobility clinic and Dr. Lee's office is the best. Like the care that I received, the referrals that I've gotten have all been totally awesome. Anyway, now I'm for sure out.
Well, that's why we chose you, Steve, is except for that little rant you went on about our archaic video system. I'm going to have you strike that next time from any presentation, or we're going to mute you at that point.
Okay.
No, that's absolutely true. It's amazing. So we were using the Ontario telemedicine stuff at the time, which was, we were fairly, really, we were part of a pilot project to use that, and as many of
right.
that was crazy. It's amazing, what a pandemic does to sort of speed along virtual care and sort of a lot of those technologies. So, no, thanks, Steve. You've had a really interesting journey up and down, and you're a super resilient guy, and you've done a lot for the clinic. So I thank you so much for sharing that story. And the other part of things that you share with that, Steve, which I think is really important, is that we always talk about but we tend to forget in primary care, and we talk about community care, but that those other issues of housing, employment, relationships, everything that's makes such a difference towards healthcare as well, right? So that's really, really important that you bring that up. I don't know if anybody has any questions or comments for Steve. I'll open that up. The other thing we should mention is if people do want to document or make comments in the chat section, to go ahead as well. But if there's any comments, feel free at this point.
Yeah, well, I just thank Steve also for sharing the story. You didn't have to give the kind words at the end, but maybe we'll get you a bottle of wine or something. Also, I want to welcome, I see Christy has joined us. I don't know if you want to just introduce yourself to the group since we've introduced ourselves already. Or not, or not, that's okay too. Okay, and any questions or comments for Steve? Okay, well, I'm going to just carry on with our agenda. So can people see the slides?
Yeah.
Yeah, okay. So, as Jamie was alluding to, we do have some objectives for today. This to bring together people with lived experience, primary care providers, support workers, researchers, really anybody who has an interest and passion, expertise in spinal cord injury and primary care together. We want to try and establish terms of reference that address the scope, membership, terms for this, and to look at communication and engagement strategies, really to help establish a network that has capacity to help with spinal cord injury work at the primary care level. And we want to have it ideally at some point across the country, and to identify some common goals for this network, and to re-identify some of the gaps that are here in primary care for individuals with spinal cord injury. So I'll turn it over to Jamie again, just to give some context of work that's been done in primary care to date.
Yeah, thanks, Joe. So again, most of you will kind of know much of this. We've worked together or been together on many presentations, but just as a bit of a background, then we'll talk a little bit about what we've done within primary care in the mobility clinic, and then just a really quick synopsis of some other things that are out there. By no means is this at all exhaustive, so it's just going to be a bit of a background. So as you all know, we established our mobility clinic in 2009-2010, funded through the Ontario Neurotrauma Foundation. The idea behind the clinic was really to model some of the other clinics we have in our family health team, such as our memory clinic and our INR clinic. Basically clinics that can help populations that aren't typically served as well within primary care. And so over that time, we've been involved in a number of different projects. Where we are right now with things is really, we've developed tools, we've developed a model, we've developed a teaching platform, and we're trying to disseminate that clinic and share the model. So in developing all those things, we've been involved in a number of projects with some of you present here today. One would have been the PRISM project, which was sort of bridging primary care and rehabilitation in a communication form. So this was back in 2014, I believe. And this actually involved using electronic consult between physiatry and primary care, which we still use today and has grown in popularity. We also started doing more virtual care in terms of OTN, as we mentioned before, video conferencing. We started that around 2015 or 16. And then that sort of morphed on to some involvement with Spinal Cord Injury Ontario and using VIP for SCI and other platforms like that. So when the pandemic finally when the pandemic hit us in March there, we were actually fairly well prepared in a lot of ways to reach out to our patients in that form, and many of them we'd already been doing that. So there was a bit of benefit, I guess, there. We've had a couple of summits back in 2016. We brought about 100 people together to look at primary care and SCI and sort of lay out, a 5-year plan in terms of research and development for the mobility clinic, and that sort of laid out those tools and dissemination of the model and refining the model. And then in March of 2020, we had our second summit in which we geared it a little bit more clinically to primary care, but also had a little bit of more facilitated discussion in the afternoon to decide where we go further. And one of the major points that came out of that was establishing a network, or a more formal network out of the informal network that had been developed. And so this is where this comes out of, and this was funded through Praxis. We've done a pandemic outreach. As mentioned, virtually, we sort of proactively did this in order to reach out to some of our mobility clinic patients that we thought would be threatened, both health and socially, etc., in the pandemic. And then as part of our network, we started some knowledge translation activities such as webinars. So to our larger group, we advertised webinars. We did one in April or June on our COVID outreach initiative. We did another one in July on virtual care, and we have one coming up December 9th on pregnancy and spinal cord injury, and another in the new year on exercise and spinal cord injury. And Joe, if you just want to go ahead there. But by no means are, we've done a couple of other things. Caring for individuals with spinal cord injury was a project done with ONF and folks at the University of Ottawa. We've been involved with the American Spinal Cord Injury Association and the Academy of Spinal Cord Injury Professionals in the primary care committee that they've developed over the past couple of years. But by no means do we, write the book on primary care types of projects. There's been lots of people who've done some really good work, and this is not exhaustive in this list, but Marian McCall and her team doing Actionable Nuggets that was funded by Rick Hansen Institute, I believe. Spinal Cord, SCIU, which is a project of John's. We have some folks that we've collaborated with from Vibrant, or who is Ann Johnson Health Station, who many of you who are in the Toronto area will know. They're a community health center that manages many people with physical disabilities and other things. And really, we modeled initially when we set up our mobility clinic, we did a visit there and modeled a lot of our structure and care after what they did. So, and actually, I think there was supposed to be a couple of folks on from them today, but maybe it's things have just come up. And then there's things such as SCI, which everybody's aware of in terms of resources. And we've had an association with our Australian friends as well, like James Middleton, and they've done a lot of work, as many would know, in primary care and other things. So there's some good learnings there. And other things to look at would be things like SCI Action Canada, when you look at exercise and how it melds into community care as well. So this, is just kind of a rundown of some things that are out there. Again, we want to look at this in a fresh lens. It's not that what we do is necessarily the be-all end-all or the appropriate thing to do. We need to get input from everybody and decide on sort of what goals and things we need to move forward.
Great, thanks, Jamie. Actually, maybe before we go forward, maybe because we have a lot of august people here on this call. Do others want to just expand on, what you seen as primary care initiatives for spinal cord injury, and share before we move on as backgrounder for the group?
I guess John Shepard here. The only thing I'd mention, and I think Jamie, you sort of alluded to the folks in Australia, but I know that James Middleton is an Australian researcher who I think has done quite a bit of work on developing resources, particularly to support people in rural or communities that don't have good access to primary care sort of infrastructure. So yeah, I just want to mention that because I think there's some published resources that are useful, and there may be additional stuff that's kind of in the gray literature that is helpful.
Yeah, thanks, John. As Jamie says, yes, we've been in touch a number of times with James Middleton and met with him a few times as well. Yeah, they have a lot of good work there. You're quite right.
It's
Go ahead, Tori.
Tori speaking. I think someone else started at the same time. Do you want to go
You
first?
can go ahead, Tori. It was me. Go ahead.
Okay. I know Swati Mehta at Parkwood has been, it's not exactly primary care, but she's been doing research on mental health and managing chronic conditions with a specific application on spinal cord injury. And we're looking at how we could incorporate some aspects of that mental health support into our regional service coordinator model. So mental health, I suppose, doesn't fall into primary care, but I would imagine it comes up all the time and you'd be doing a lot of referrals out and there'd be the wait list challenge. So I guess that gap, the where to refer and how long are the wait lists and what is covered and what isn't covered, that's something that comes up for us all the time.
Yeah, thanks, Tori. I would actually say that in Canada, most mental health services are actually in primary care, be they family physicians or social workers or other mental health workers. And those that go to get referred to, say, a psychiatrist or other specialists is actually a minority of folks. And so mental health is very much situated largely in primary care. And so that's great. We would be very interested in that aspect.
Yeah, and Tori, so we have connected with Swati. So she's been at our summit in March, and then we've had a few connections with her since that time. So, and her project in terms of reaching out to folks, we have disseminated some of her material to some of our patients or persons with the experience that we see in the clinic. She has been involved with a couple of other things that we're doing right now, and she's part of our larger network. So to say, and then we've also helped her recruit some folks who do some of the actual counseling. And I definitely echo what Joe says. That's a major part of things for sure in primary care. And as you pointed on, really, access is a huge issue, right? So those kinds of projects, and I know that the things that you guys have done through SCI Ontario and through your website and some of the mental health resources there, especially during the COVID time, have been immensely helpful for what we have done. And it also brings up one last good point, is that this primary care thing is very broad. Like our general network of folks includes allied health, support people, hopefully things like home care, so that we're not talking just like family medicine for sure.
I do not know if the group knows, there's another project which is being led by Eldon Lowe. It is on looking at healthcare utilization during COVID. And he's looking at 3 populations, that is stroke, traumatic brain injury, as spinal cord injury. So it would be a good thing to know how things went through during COVID. I do not know from what is the start and the end period of that project, but it is ongoing project and they have started recruiting people on that. But where did these people go during COVID? Would be interesting to see from primary care perspective as well.
Thanks, Tara. Certainly mental health issues have been huge during this pandemic for really all populations and particularly patients who are at high risk. And Eldon has been part of our network as well. In fact, I think we asked him to join us today, but he had a scheduling conflict.
Jamie and Joe, I am just wondering if you have looked at the US Veterans Affairs model for spinal cord injury care, because while it doesn't specify necessarily primary care, it is actually integrated into their care model, so that there are some very clear definitions as to what it uses a hub and spoke system basically. And in the spoke sites, primary care is actually integrated into that model. And there are some very clear accountability and also requirements for the hub and spoke systems to work together. So I don't know if you had a chance to look into that, because I think that there may be some good resources and models to borrow as well.
Yeah, Chester, a really good point. I think we looked at that a number of years back. Well, a number of years back when we were just looking at setting up the mobility clinic model, and we sort of referred back to that. And when we looked at sort of developing tools and disseminating the clinic, that is definitely something that we kind of modeled it after a little bit. Like we sort of always talked about the mobility clinic as like there would always be those connections that you're kind of talking about. So, we would probably act as mainly kind of a hub at the mobility clinic where we develop things. And then we would always provide communication or support virtually, do ongoing sort of updates, and supply tools and resources, whether it be electronic EMR tools and that sort of thing. So it has been kind of based on that. It might be good to relook at that though again as well. So I think you bring up a good point, because the way that is run does seem very, very good. And you would of course have even more experience with it than I would, probably through some of your physiatry colleagues and that sort of thing as well.
Yeah, I would echo Jamie's comments that, I mean, we have looked at the VA model and definitely lots of good work there for sure. And I think particularly in Ontario right now, with our transformation into the Ontario Health Team model, which is actually looking at it from a population-based accountability and looking at trying to break down silos of funding, because that's been a big problem between, acute care, rehab, primary care, community care. The funding is so siloed, it makes it so hard to really integrate. But the VA model would be a good example of bundling care for better and cheaper care at the end of the day. And I think that is actually part of the model for, in Ontario at least, for this huge Ontario Health Team transition. So I do think Jamie's right. We should be looking at that again and trying to figure out how we integrate these things better in a more systematic way.
Yeah, I think that would be great, because I love looking at the care models for spinal cord injury. And one of the things that we actually, some of you are involved in that, including Vanessa here. We just published a paper on the scoping review of models of care for spinal cord injury in the Journal of Neurotrauma. And we basically, found that there are very few models that really are comprehensive. But then the VA one is a very good example. And I think that in looking at how primary care, really contributes to the care of people with SCI, I think that one perspective is to look at the entire care model and see how that actually works within that care model. I think that obviously looking at specific resources for primary care and things like that would be critically important. But looking at how the whole care model works and how we actually have the specific role of primary care in that care model, I think is also quite important as well.
Vanessa, I just wanted to really build, just to add to what Chester, you were saying, because I think in Canada, thinking of it as a care model, we are working at Praxis with the Health Standards Organization. So at the top layer, looking at accreditation and re-looking at how accreditation is done from a patient-centered journey. So from the time of injury as they move out to the community. So primary care would have a key role there. And then there's also the Canadian, as you know, Jamie and Chester and Colleen, a number of others were at the Canadian Spinal Cord Injury Practice Guidelines that are being led by Kathy Craven and Mark Bailey. And that will also have the best practices related, and primary care is included there. So those would be two, if we're thinking, as Chester was talking about, this building this model of care, having standards, best practices, indicators and resources, and then the data through the consortium supported again by ONF. And that might be a nice way to build in all those pieces. Just a thought.
Yeah, really good thought. Thanks, Vanessa. Lots of bridges to continue to build, eh? Are there other thoughts that people want to share? Okay, if not, then maybe I'll move us forward to just talk about this network that we're trying to wrestle with. And so so we have drafted some objectives for this network, and thought we'd just put it by the group here for just comments, questions, suggestions. So one of the objectives is to establish a Canada-wide primary care network of individuals from all stakeholders, including people with lived experience, clinicians, educators, researchers, policymakers, and others. Maybe I'll just leave that statement there and just see what people think of that. And do you have any suggestions or comments about that as an objective for this network? Maybe I'll just ask, is it stunned silence of agreement or stunned silence of thinking it's terrible?
Just thinking, Joe, just thinking.
Take your time.
I guess I have a question about, I mean, this comes up whenever, healthcare is a provincial jurisdiction, right? It comes under provincial jurisdiction. So whenever we have, national initiatives, there's a question of sort of jurisdictional overlap. I'm just wondering what your thoughts are about that. And the other question is, is there any, would it be helpful to work with something like the College of Family Physicians of Canada or some group like that, on this kind of thing?
Yeah, well, I guess from, maybe I won't speak specifically for Jamie, but I know, I mean, we work with the college somewhat. I'm not sure that there's anybody specifically there that who we would engage. If we did, we would. Although, both the Ontario College and the Canadian College, I think, are generally supportive of the ideas, but I'm not sure that they have specific people who would be outreaching.
Yeah, and I think in the question, I do agree with that, Joe. We have reached out to them and some of the other organizations. done many presentations at some of the conferences and that type of thing. I think it's important, like you bring, it's sometimes easy to forget them, John, so we always have to continue to engage them. It definitely, just in all reality, isn't something that's high on their priority list, which is, always the thing that comes up. It's our, it should be our purpose to make that high on the priority list, so we need to continue to further that, but that's been some of the reality of it. In answer to the national sort of form of this, we've grappled with that a little bit as well, because as you said, it can create some complexities in terms of what we want to try to do. I mean, we can look at this, we definitely we're probably going to end up focusing more on the Ontario situation, because that's what we do and where we are, and we want to move some of our stuff forward. We do feel that if we can move things forward in Ontario, we can translate that nationally. But at the exact same time, we want to make sure that the national voices are always there. Like, I know Chester, for example, has a big interest in doing things in Alberta. So we need to hear that as we move forward. And I know Colleen has, there's going to be definitely very different things that happen in New Brunswick. And I think the learnings that we get from those things can apply to what we do in Ontario and how we break through some barriers like remote areas and such. So I think it's going to be a little Ontario-centric, but with the national lens.
So I think, Jamie and Joe, in answering your objective, won't it be tied to what will be the mandate of this network? So what do we really want this network to do? So some of those things will be tied to each other. And then which will be the center, who will be the leading, how we will have. So I think there will be a couple of other questions coming. I think you might have done those. But I think some of these things are tied in to each other.
You're quite right, Tara. I mean, and I would say the terms are always fluid, and this is going to be a dynamic process. Maybe we are much more Ontario-centric. I suppose if we were to have a vision, our vision would be someday to truly have this more national in scope.
I think Joe and Jamie, I think this may just be semantics, but my comment here is, when I look at this objective, it looks like it's a primary care network. So people may look at this and say, what are you and Colleen doing there? You're not in primary care. Or is it really to establish a network with a focus on the primary care issues for people with SCI? And so that's just a thought.
That's a good thought that that occurred to me as I was reading it out and thinking of the audience that we have, that we should change that to establish a network of individuals with a focus on primary care.
Yeah, that makes a lot more sense for me.
Great.
I see people like Chester and I as being, I see us as part of a team, which includes primary care, and any way that we can support primary care is going to help our patients. I see it as a very collaborative type of approach, as opposed to us being a primary care network.
Yes, good point.
Also, Joe and Ginny,
we invited all of you for a reason.
Also, I was noticing on your first slide, it's very much, we're here for individuals with spinal cord injury. So again, it may just be wording, but I don't know if this would be reflective, but a patient-centered model of primary care, or it's really the team coming around the patient to help them on their journey or providing them with needs. So it may just be wording, but may reflect your first slide. It's all about the individuals.
Yes, good reminder. We should be explicit that way.
Yeah, Joe, if you can include the funders as well, who are funders somewhere. I think it's somewhere, how are we going to see the allied people who are involved in the care? Is that going to be part and parcel? Because when we are saying community care or primary care, how are we going to look at that whole model of community care within this network.
So maybe we should put a focus on, so a network with a focus on primary and community care. Would that be better as well?
I will look for consensus from this whole group. That is just my thought and suggestion, that when primary care is just a part of what people live in when they're in the community, but how do we circle everything else around that? Rehab is also important component of the ongoing care for people post-discharge, but how can we connect all these things in their care plan?
I like this. I think it's a friendly suggestion, to be honest, and I think it's a good suggestion.
Joe, this is Shannon. What suggestion may be to actually define what constitutes primary care? Because I think the terms community care or primary care we commonly use and we know, but as you all alluded to, there are many components: mental health, accessibility issues, et cetera, et cetera. So there might be an opportunity to define it in the context of this work, what constitutes primary care for our SCI community.
Yeah, I think that's a fair point. We usually define primary care differently than primary health care, which to the outside people makes zero sense whatsoever. But yeah, in the primary care world, there are semantic differences between these terms. So I think you're right. It's probably good for us to have definition of the term somewhere. Other comments, suggestions, questions?
I guess, I'd be interested in talking about scope, and this may be jumping the gun, so I'll just say it briefly and maybe come back to it, at a more appropriate time. But
John, there's no time like
from the research perspective.
Go ahead.
Okay, great. Well, then, good. So, from a research perspective, I'm really interested, in knowing what extent you'd like to look into, sort of, data on what's actually happening, because my sense, and Vanessa, for example, or others who are involved in this work might be able to speak to this, but I know, other groups are meeting to draw together data on what happens in terms of the sort of trajectories of people with SCI in the community, but there isn't much out there. And a lot of the activities right now are focusing on, care provided in hospitals, acute or rehab hospitals, and there isn't much of an infrastructure to, even to gather data on primary and community care. I know it's something that Risker is interested in and looking into, and it's certainly something that my work, my sort of PhD academic work is going to focus on. But is that an area of interest, or is that kind of separate from the mandate of what this group would be?
I think it would be coupled with it for sure, because I think that data can be used for research and evaluation, and I think that that type of data, as we go forward with, particularly in Ontario, again, I mentioned Ontario Health and Ontario Health teams, theoretically, and stated, it's supposed to be data driven for policy change. And so it'd be very hard to affect policy change from a research and an evaluation standpoint without data. So I think you're quite right in there.
Yeah, and I think, we ultimately at the end of the day might decide on a few goals. I mean, something like that might be something to think about, John. It's something that's been tossed around an awful lot, that it's something we need to get going on. And certainly there are, as you know, some barriers to it, but how do we start to overcome some of those things? I think that's really important. When we look at projects within primary care right now that are projects probably anywhere in healthcare, as Joe mentioned, have data behind them. So, we look at our memory clinic, as a model that we do out of here that's, you know, Dr. Lee has established 100+ memory clinics, has shown financial value in terms of these clinics. And Joe could speak more to that. But even more recently, a project that we're getting involved with, or that is involved in Southwestern Ontario, is a COPD-led clinic that will be involved. And they actually have some really good data as well in terms of, you know, efficacy of care and cost effectiveness. So I think that that's super important.
I also want to add to that too, because for the work that we are doing in Alberta, we're looking at healthcare utilization by people with spinal cord injury in the community versus, you know, in the, let's say, rural communities versus those in metropolitan areas. And that's just one example, right, to look at how the population-based, you know, statistics and data may help us, because I think that part of the barriers, to be blunt about it, is that I don't seem to get a lot of help or attention in some areas in healthcare, because people don't actually see the value, and their value could be based on, you know, just the population size. They sometimes think that, okay, you have such a small population, so no, we're going to pay attention to stroke and diabetes and things like that. And so spinal cord injury, you have so few patients, we don't really care about you. And yet they fail to look at the actual overall picture. And when we look at healthcare utilization and things like that, then they quickly realize that it's not really the full picture, right? When you just look at the population size. And so I think that similarly, if we look at you know, how primary care and people in the community actually utilize care along their life journey after the SCI, it actually will be extremely expensive. Of course, that's not necessarily the reason why we want to do this, but to convince some people to actually pay attention to this, I think that that data will be invaluable.
Yeah, and I think if we have a strong network, we can leverage, you know, each other to help make this data and measure this data, because, you know, it's out there to be measured, and we can affect policy change. You know, as Jamie's saying, you know, for the memory clinic model for dementia, you know, the primary care model has been shown to save $26,000 per person seen in each clinic each year by delays in emergency room use, delays in hospitalization, rehospitalization, and delays in long-term care placement. And you know, that you know, type of money, $26,000 per person, gets the attention of government, you know, to change policy, to say, hey, what you're saying does make sense. It's not just better for people, but it saves us money too. And so, which, you know, good care does save money in the end, equity and all sorts of positive things. But at the end of the day, right now, you know, governments are looking to save money. So we really have to have that data. And we're hoping that this type of, so thanks for bringing it up, John. I do think that, you know, as we're speaking about, you know, some of the, what the network could do, that's what we envision, you know, are the types of discussions and the good things that might come from it. So thanks for bringing it up. We'll just move on to another objective that we had drafted. It would be to help develop and disseminate best practices into primary care, maybe primary and community care, and assist in knowledge translation, and invite again, questions, comments, suggestions, and thoughts on how something like a network like this might actuate that, and is that a reasonable objective?
Joe, I like that, because I think that if we actually have some standards out there, then basically we can inform people that, you know, if they are following or not following the best practice or the standards, I think that would be very useful.
Vanessa, I also agree with Chester and think it really builds nicely on the special issue that you had in the topics of spinal cord injury rehabilitation, where you laid out some of the best practices. And then I think in this network, it is taking it from a publication that we know doesn't always result in a practice change, but bringing those toolkits to meetings or webinars so that to facilitate the implementation. I also just wanted to add for the point, your previous objective, if you're looking for language of bringing in the data piece, there is a model called the Learning Health Systems. And the whole basis is that as you implement, you're using data to feed back in a very QI cycle. And so in BC and now in Saskatchewan, the ministries of health are talking about these learning health systems. And so it might be just some language to build in John Shepherd's point about how data is so critical to this work. So just thought I'd add that for the previous objective.
Thank you. We need all the help we can get with those things. There's always, yeah, but that sounds great. Good language.
So I'll share just a paper that came out of the Institute of Medicine and now being adopted in BC. I think there's a lot in Hamilton as well around learning health systems I can share if it's as a resource.
That's great, Vanessa. And just to also mention, as everybody probably knows, we're taking copious notes on this sort of stuff with our research team to make some changes. So all ideas are great.
Yeah, so don't count on Jamie and me, but we have the team behind us.
Can I just ask you, Jamie and Joe, in terms of, in the primary care world, are there like, specific gold standards for specialty care that people, people have from a specific source? Like, are there specific sources like your college or whatever, right? I don't know, or kind of professional organization for primary care that actually is like the go-to place for people to look at these resources? And if that's the case, is it like really important to make sure that the best practice or the standards really become part of that?
Yeah,
standard?
I think I understand what you're saying, Chester. So maybe the short answer is no, because we have something called, if you can believe it, guidelines for guidelines. There are so many bodies who give us guidelines about this, that, and the other condition that it's very hard to sort out, because it's not just, for example, the Canadian College of Family Physicians, this is the way you should treat condition X, COPD guidelines. We have guidelines that come out the yin yang from many, many places, and there is not one place that primary care can just say, this is what it is for sure. Although, I suppose there's certain areas where there's more consensus than others, because there's probably less competing interests to publish it, if that makes any sense in what I'm saying, what we're saying. And I wonder whether a network like this, if we do actually, if we are able to set some standards in primary care, and align it with the Canadian College and other bodies, I'm not sure that there's not a whole lot of competition for these sorts of guidelines. But Jamie, did you have some thoughts?
Yeah, so Chester, that's a good point. I think here, is there a one-stop shop for sort of everything might be a question as well. When a family doctor wants to look for one thing, can he go to one place on all things? And as Joe said, no. And so that is what makes it tough. But there have been some success stories I would think of in primary care and other places. So, we were on a summit the other day, and I talked a little bit about some of this stuff. But for example, the Choosing Wisely sort of program, which is a whole medicine type of thing, which looks at us putting more thought into the kind of tests we order, is a good example of something that works well, I think, within healthcare and educating the population to some extent. When I think of around Ontario as well, I sort of think The Center for Effective Practice does a pretty good job with some of their academic detailing around guidelines. They've done a good job with COVID and other things. We have approached them before. It's quite costly to do something like that, if I remember right. But that is something to definitely, think about maybe reapproaching something like that. But yeah, unfortunately, there isn't one spot.
Yeah, and maybe just to add, particularly for, because we were just, talking in the degenerative cervical myelopathy summit thing that Jamie and Micah Failings and others are holding. There was reference to a program in Ontario, which is Isaic, which is actually being rebranded as the, what is it, low back.
It's a rapid access.
Rapid access. Yeah, rapid access center for low back or something like that. And which is similar to, there's a rapid access clinics for hip and knees as well. And so it's like trying to disseminate best practices through clinics that are built with specific criteria and with uniform training in the province to try and triage a lot of things. And my involvement in some of those things has made me wonder whether somehow someday, for spinal cord injury, maybe there's a way of tacking onto that type of model for some of this, because that is also a way of disseminating best practice. Because you're quite right, from the translation from publication to actual practice, actually at our national family medicine conference that was just done a couple weeks ago, the keynote speaker was speaking about how long it is for that, and gave an example like of H. pylori for ulcer disease. It was 17 years between the guy in Australia saying that it's H. pylori and being laughed at and ridiculed until we started adopt saying, hey, okay, we should be treating it that way. There's a long time, and that's not unusual. That's very typical of a long delay in the adoption of best practices. So are there other thoughts about this this objective? Okay, if not, I'll go on to the next objective, which is to communicate and promote primary care for individuals with SCI through research projects, education, summits, and other collaborations. Thoughts?
I think that's a pretty nice I like that one. I like that. I guess because I see like, oh, we're already doing some of that, which is nice because then you can check off a box. But no, I think it's really I've really seen the value of the collaborative approach to some of these initiatives, particularly when involving persons with lived experience and the community. Like if on the grand scheme of, and that's to me where the closest interface of community is your primary care. And the farther away you are from a hospital, I think the better. In terms of, I don't mean geographically, I just mean keeping you out of hospital is so important. And so I think involving the community as well as primary care, I don't know if there's a way to weave who the collaborators are into this, or if it's just reflected with the previous objectives. But I think this is really important.
Yes, and perhaps, similar to the previous suggestion, maybe we should say promote primary and community care.
I think it has been very helpful when we have held our 2 summits to bring people together again, to think through what we have. Like in 2016, we had our first primary care summit, so we brought people from different areas as suggested from, and we had not only primary care people, other folks as well as people with lived experience and things like that. I think having those events at a certain point in time, it is helpful, and we had a follow-up summit. But maybe in between, we have some kind of other things to share our information and bringing people working on something. So unless there is an effort to do something, these things does not happen on their own. So all the things which we have mentioned are very helpful in one way or the other.
Thanks, Tara.
And Jamie and Joe, I also think that this is a very important objective. My only comment is, again, this may just be some semantics. So now, with the way that it is phrased now, having research projects as the first item, is that going to be the most helpful way for this, or should we actually really think about, naming things like collaboration and education, etc. first? Because I think that sometimes some people, being a researcher, I live through it every day. People kind of poo-poo research stuff. They think that that's not my role. I don't do research. I take care of patients. And but they don't understand necessarily that, okay, this should be integrated, and also sometimes research can be very helpful too. But with the point that, let's say, if we state collaboration first, then collaboration can lead to education and research, etc. Would that be more helpful? I'm just wondering.
I think you're the master of semantics there, Chester. And sorry to hear that that people poo-poo research.
Well, and I think it's a good point, because it sort of, it directly sort of speaks to what Colleen just said about the collaboration as well. Like, she sort of mentions the importance of that. So maybe it is good to rework that. What do others think about that?
I think collaboration is very inclusive word. So everybody thinks they are part of it, and it will even enhance your community engagement.
How about something like to communicate and promote primary and community care for individuals with SCI through collaborative care, education, research projects, summits, and other collaborative activities.
Can we add family?
I don't know if you have to name summits, maybe, Joe. Maybe that's just part of the communication strategy. Because you're not naming webinars and everything either.
Yeah, fair point.
Can we include families as well? Because that's coming out everywhere, that let's be very explicit that we include the word family as well, though we think individual SCI covers that, but if we can make that explicit, and families.
That's a good idea.
I guess the other thing I might think along this line is what does a communication strategy look like? Do any people have any? We're talking about summits and webinars and that kind of stuff, but does anybody have any thoughts about good ideas for communication? Like, we do have, we do email people, but do people get too many emails? Is Twitter and our website an adequate communication strategy, or is there a better way? I just kind of throw that out there as well.
Could I mention a crazy. It's a crazy idea. I mean, related directly, Jamie, to this point of communication, and it's one that was discussed years ago at ONF. I remember talking about this, Tara, with you and Kent, and the idea was to disseminate knowledge to primary care physicians via patients. So it's taking the academic detailing model, but instead of having pharmaceutical reps doing the detailing, we're having patients doing the detailing. So if we had, something like a toolkit for primary care physicians on, care priorities for people with spinal cord injury, we could work with organizations like SCI Ontario to disseminate that to patients and have them bring that into their primary care physician. I know there might be issues around a physician's acceptance of it, although having the material of ONF would probably help. But it's an idea that I think has been discussed, but it's never really been tried. So I just wanted to mention it to bring it back from the past and to see if it's an idea that still has some appeal.
Yeah,
I think Joe and JB saw that. It was the toolkit which you had developed, John. So maybe we can look at if we can give a life.
Yeah, no, that's a really good point. I mean, so we did do that with SCIO Ontario when it was sort of like the pamphlet of bring this to your doctor when we were sort of promoting the primary care and some of the initiatives with the government at the time. But I completely agree with that. I think the army to do this is really the people with lived experience. And, when I sit on the Asia Primary Care Committee as well, like last week we had a conversation about this, John, and it was the exact same thing. The people who have to bring, I always talk about you need this multi-pronged approach. Like we can sit here and try to work on primary care and others, but really the main movement's going to come from the people with lived experience taking that in. I totally agree. So I think that that's really worth kind of relooking at that and how you do that in an effective and meaningful way again.
Jamie, it's Peter here. I actually think we need a multi-pronged approach and not to weigh heavily on the patient. As you know, we've done the take this card to your doctor, and we evaluated how people with spinal cord injuries were taking information to their doctor. And it really depends on the personality of the doctor to accept the information by the individual and to work with it. We can't say that that wasn't a successful initiative, because in some cases it was quite successful and people were keen, and it led to the development of better primary care models within the mobility clinic. But in other instances, there was an attitude around, this is the way I run my practice, and I'm not changing. And so I think we need to be realistic around, well, how we do multiple prong approaches to benefit collectively, because I don't think one sole approach is going to get us to where we think we want to be.
Yeah, no, totally right, Peter. And that's really good that you bring that up. I don't mean to say that would be the only way we'd go. And actually, in that discussion with the Asia persons as well, it was sort of, they're actually maybe looking at it, producing something along the lines of like, how do you approach your doctor with that? Because it does take some nuance to doing that. Like, I mean, there is this potential power differential, right? That's well recognized. And you're exactly right. I mean, certain doctors are very receptive and others aren't. And it's all about how much do you take them? Because, I mean, if you open up a folder of 20 pages, well, you've lost the person right away, right? As opposed to maybe you just have one sheet like what we did.
Well, we also have seen this in the expansion of virtual healthcare, right? Where, VIP for SCI was well intended to be a cross application where doctors can use it. But what came very clear after the pandemic and when virtual care expedited exponentially, that, there wasn't an opportunity to talk about what components you wanted in a virtual care platform. It was more driven by the family physician saying, this is the platform I'm using. And I'm not interested in using 5 different platforms based on my population base. I want to be as efficient as I can in my own practice, and I would like something that is encompassing to all. And if there's limitations, well, that's just good enough for me. Is kind of the responses we're getting in the evaluation.
Yeah, I think you're quite right on that, Peter. And so, yes, we learn as we go. And so going back to what John said, not a crazy idea whatsoever, and a good one to relook at again, for sure. As part of, as stated, I think a multi-pronged approach, for sure.
Great.
For this objective, it's Vanessa, just wondering in the wording about through research projects, is this objective, do you see primarily about knowledge sharing, about the evidence coming from research? Because I also could see reading into it, it's an ability to collaborate, which would be, I guess, more active on the related initiatives coming from primary care. So just wondering your thoughts on the what you were looking for, more the knowledge sharing or the collaborations.
I think they would be all and, yes.
Okay.
Inclusive of those.
So the term we've used at Praxis is to promote knowledge sharing, which could be evidence coming in a variety of ways from these various vehicles that you have there through summits or research, and then to promote collaborations might be some just wording to consider.
You have a way with words, Vanessa. Okay, maybe we'll move on to speaking about such network and the membership. And so we listed, kind of a pile of groups of people. Maybe we can just read through the list here and give comment on, are there other folks who we've not put here who we ought to?
Actually, Joe, as you saw in the DCM summit as well, that acute care is always thought that people go to acute care only before as soon after their injury. But I think they play a role in this primary care initiative or a network we are developing, so they can bring us the issue what they see and what primary care sees, so we can bridge that gap. Because right now I see them very excluded from others. Primary care talks to rehab a bit, but acute care is totally a different entity in many ways. So if we can, if you think they will be a part of this, I will be helpful, especially now we're taking non-traumatic SCI as a big issue.
Well, maybe it would be acute care and rehab providers with expertise in SCI as a line. Would that be fair?
Or involved in care of SCI and SCI people, individual injury, maybe expertise or not, but who are involved in care. Any, okay. I am not in the wordsmithing, whatever best is suitable when you are writing this thing in memberships.
Maybe clinicians might be good, and you might have examples of primary care, physiatry, acute care, because we do also have a number of allied health that are part of the network.
Okay. Other thoughts? Suggestions?
Yeah, Joe and Jamie, just to go back to the previous discussion on data, I know this may be already included in some of these different groupings, but I think it may be useful to, if we agree that this is an emphasis, to have someone who's really going to be able to access data and also to do analysis and to look at the health economic side of things. So, if that is already included in like researchers and other categories, that may be fine. But if we think that that's actually a major focus, we may want to actually have someone with that expertise to be specified.
That sounds good. So, those with expertise in what it would be, health economics, data,
system.
Okay, any other comments? Okay, we thought that this network should have a steering committee. I've been on some steering committees where they use a 2 pizza rule, meaning there should be no more people than would be able to eat 2 pizzas. So I guess it depends how many people, how many slices people have, but generally not having it too big so that it's nimble enough to steer the network. And so the thought was maybe to have, 12 or 16 or some number of people. You want enough so that there's diverse conversation. You want it to be small enough to be nimble. We want representation from all stakeholder groups, and to provide the leadership and recommendations to the wider network, such as, are we planning summits? Are we planning certain research projects that are focused on primary community care, education programs, other collaborations? Thoughts, suggestions on such a steering committee, and how and who should we recruit to fill these roles? I mean, we have some ideas, but we don't want to prejudice it by this being about us.
Joe, just a suggestion in your previous slide to include people from indigenous communities as well, Francophone and indigenous communities, to get some perspective from their healthcare perspective and the way the primary care is need to be delivered in those communities.
That's a good thought. Maybe we can somehow word it with regards to having an equity lens.
Yeah. Like refugee communities, you have a big refugee community in your KW area. So how can we, used to be word marginalized, now they are bringing it more better than wording than that, or special groups they are saying, but whatever is the lingo which they are using, we can use that. But I think it will be good to have people representative from those particular sectors.
Yeah, I think it's I think it's good to have people who really represent the community, including those with an equity lens, because there are, I suppose the term would be, historically disadvantaged groups, without even expressly naming them.
Yeah, I think that's a great point. I would strongly support it. An equity focus. Another consideration I think would be connections with other kind of aligned efforts. So I think it would be good to have people who could bridge the gap between these activities and similar or adjacent activities in the worlds of research, quality improvement, and connections to important organizations like ONF Praxis, SCIO. So
that would make sense. Chester?
I was just wondering, Jimmy and Joe, that this kind of the comment by Tara reminded me of something else too, that's maybe related. And do you want to also have special considerations for primary care practices or providers in the very rural areas, because I think that the challenges and the issues they have are quite different from the primary care practices in the more metropolitan areas. And that really came to my attention as we are doing this work in Alberta, looking at how to transition people back to the community. It's such a different experience when we look at the rural practices versus the more metropolitan areas.
I would agree with you 100%. I would say in the work that some of us have had with the Ontario Health teams, when talking about an equity lens, it does include those in rural, remote areas, as well as those who have historical disadvantage for other reasons, for sure.
One thing that we learned from our Alberta experience and data analysis was that I was actually quite surprised to see that. I don't know why I'm surprised, but somehow I had some assumption there that maybe I shouldn't have. We found that in the rural areas, actually, about a third of Albertans with SCI actually live in the rural areas. And I somehow made the assumption that, the vast majority would be living in the, more urban areas, but I was wrong. As high as 1/3, live in the rural areas. And so that really got me thinking as well.
Yeah, I think that's a good reminder because, our rural colleagues frequently feel left out of the conversation of lots of care. And that, I mean, people live where they do, and they do for many reasons.
And when we are talking about people living in community, I would like to even see people from long-term care facilities that are group homes get their experience in as well. So somebody like me living in a home is different experience than somebody who's like living with spinal cord injury in a long-term facility. That might be anything like a group home or things like that. So there are a lot of people there. So I think getting their perspective and how they see primary care through the services they get, I think will be important to include here.
Now, maybe I'll just share, because it's a small group, when Jamie and myself and our team have been chatting a bit about this, there's the theoretical of how to recruit, and we want to be open, transparent, fair, equitable, and so on. There's also the practicality of who can we actually get to join. Being very honest, it's not like we put out something and there's 100 applicants for a spot. That's not been our experience anyway. Usually we're twisting it's the other way around. We're twisting arms of people to actually join us.
Yes.
And even with all of Jamie's charm, that's still true. So so we're wondering, asking you as colleagues, who and how do you think we should best actuate this recruitment onto this? I mean, we have some ideas, and I mean, we could ask, many of the people here if you'd be willing to join on this sort of thing. But, we want to have it also to be a process which seems to be, open, fair, and not just, because we're tapping people on the shoulder, so to speak, necessarily. So any thoughts, suggestions for us on that?
One approach might be to look at the attributes of the steering committee. So how many of the funder groups that we discussed, how many of those there were. And then if you're also looking to balance for, I don't know, gender, Indigenous, to get those perspectives. Probably in the community phase, trauma, non-trauma causes may likely be not as important, but they may be. And then if you have your attributes of the steering committee and the linkages, then see on your potential list of people who could cover, as John was saying, that folks like Jamie can cover off the linkages to Asia. So he could wear those hats, and then it might get you with a shortened list, which you could then recruit from. Just a thought.
Great.
Does the steering committee has to be Canadian centric, or are you looking for some person from outside to give some input to this work? And I think if we draft a recruitment letter, what we are looking from these people, what much is the input required for steering committee, may be helpful for us to think and see how we can involve those people. And somebody who has not been involved, I would really like to see some not been very active and come and participated. And there are a lot of people who are looking for some of those things as well. And it's not easy to recruit. I totally agree.
Okay, sorry, Tara, you're cutting out for me at least a little bit. The gist of what I thought I heard was that, you know, we probably should be setting some terms and conditions for the, you know, being on the steering committee and maybe filling it out. And we were going to ask some questions later with regards to those things on what people thought would be reasonable.
I think then we can resolve that. So I think that would also give us some idea who to suggest and where to go for it.
Okay. Now, I can go on. I'm just trying to be mindful of time too. You know, we really appreciate the discussion. Do people want a little break and then we can reconvene in, you know, 10 minutes or so? Or what is the will of the group at this point in time?
I'm just going to keep it going because I couldn't wait for the break, so I had to take a personal break in between. So I don't know if people just keep taking breaks as they need them. I'd rather finish early and keep going.
Sounds good to me.
Yeah, that's good to know.
As chair, you may need a break, so.
Good for me as well.
Okay, how about this? For sure, if people need to take a break, please take a break. Why don't we just plow through too, and we'll try and end early. Is that fair?
Yeah.
Okay. All right. So we can talk more about this. Maybe we'll just go on with some of the other discussion questions. We wanted to discuss about the communication and engagement strategy for such network. So thoughts of, you know, yearly summit, or, and if not a summit, some type of similar gathering with regards to knowledge translation priorities, alignment, perhaps having things like webinars quarterly as an example, have collective or collaborative research, where maybe look at the development of some national primary care guidelines. That was kind of alluding to what Chester was saying about, do we have national primary care guidelines? And, you know, we're suggesting perhaps this body could help forward that as a goal sometime. Anyway, those are just some of our thoughts, and wanted to open up to the group for your thoughts.
Joe and Jamie, I just got a comment on webinars, and now I have to confess, I actually did forward the recent webinar on SCI primary care to our primary care groups in Alberta. I had 0 response. I was so disappointed. And I think that people may be getting tons of webinar invitations now. And so that could be an issue. But also, I don't know, maybe the webinars are for those who are converted or semi-converted. But for those who are non-converted, that may not interest them. I don't know. And so I'm just wondering, I mean, don't get me wrong, I think that could be useful, but could there be other ways to entice people as well? Like, are there things that could give people CMEs or whatever? I don't know. And I don't have the solution or suggestion, but I'm just reflecting on what happened recently with that webinar.
Yeah, I think your experience would be, to us, not surprising. Because we do get a plethora of invitations for this, that, and the other thing. So typically, our webinars are speaking to people we've had connection with, who clearly have had some sort of interest at some point in time, or personal connection, or there's some reason why they would even look at it in the first place. And so I think at least when we're thinking about these webinars, it would be to actually have the net and people who are part of the network as part of these webinars, as opposed to further outreach into primary care. But Jamie and I try and flog things at the National Family Medicine Conference, and that sort of thing. And there's limited, it's not like we're the most popular people there, so there is only a certain amount of uptake for the subject.
It's Tori speaking. Can I jump in on the webinar question?
Sure, please.
So one area where we had success with you, Joe and Jamie, was when we partnered with OTN and they marketed the certified webinar to their network of primary care physicians. And it was really where they have the most active and engaged members was new family doctors. Now, I will say pursuing the certification for a webinar is a gigantic pain in the neck.
That's okay. We edit the minutes.
I couldn't believe how time consuming it was. It was ridiculously time consuming. And that's the Canadian, I guess, Canadian Medical Association that sets those standards for 1 versus 3 credits. I won't go on and on about that.
It's the Canadian College of Family Physicians.
Oh, there we go. Okay. So we'd pursued certification thinking that would be a marker of quality, and it is, but I don't know still if I'm not sure about the return on investment for the hours required. Definitely, I think for Joe and Jamie, for you, one of the ways it worked was you had a research assistant, or you had somebody, not both of you, who could help with filling out all of the cumbersome applications. And then definitely having OTN market it to their network with no additional resources or investment on our part. That was key, and they're no longer doing that. Their funding was cut last year. So all that to say, on the webinar front, that's definitely a place where we're happy to be engaged, and it fits really well with the knowledge exchange mandate. And I agree with the strategy to focus on growing the engagement of the folks that have already bought in, reaching primary care providers who may have only 1 or 2 people with SCI in their practice. It's a real challenge. The other strategy that's been helpful, and I don't know I don't know how this resonates, but the broadest possible umbrella. So we worked last year, we did another session on bladder management for people with SCI and other neurological conditions. So broadening it to everyone using catheters for daily use. That was helpful in making the links. So it's like people with MS, people with spina bifida, people with spinal cord injury. It doesn't always apply, but where it does, that's a strategy that's been helpful for us.
Thanks for the comments, Tori. I think that in primary care, yeah, the appeal is when it can be more generalized to other conditions as well.
So I just wanted to add, it's Charlene, also promoting and relying on members' communication channels as well. because each member will have their own communication channels, websites, social media, etc., and really promoting through those various channels as well. And the other point I wanted to add is that whole concept of, I think there is a bit of a Zoom fatigue going on, and I think that's also going to become even worse after the pandemic is over. So having an adaptable communication strategy so that we'll see, I think, in the next year or so, hopefully once the pandemic is over, I think online virtual participation is going to go down because people are just simply, I think, getting tired of it. So having an adaptable strategy so that, you know, should that happen, you know, more innovative opportunities can be explored for communication. And then the last communication opportunity I wanted to add, and Vanessa probably can have a bit more information about this, is that SCOS 2021 will be happening here in Vancouver next year in September. And that would also be a great, hopefully in-person opportunity to share some of the work.
Yeah, thanks, Charlene. Yeah, that would be great if we have an in-person ISCOS conference in Vancouver next year. Yeah, who would have thought that there would be such a thing as Zoom fatigue? But I think everybody understands what you mean. Whereas, you know, a year ago, hardly anybody knew what Zoom was. So it's quite amazing. But you raised some good points there. Thank you.
Joe and Jamie, one of the things that I saw coming out of the UK with the NHS work is that they have done some really effective short videos that actually got quite a few hits on YouTube, etc., to get some points across on healthcare. And that included some of the COVID work as well as wound care work, pressure injuries, etc. And I actually don't know, if there is evidence to suggest that they are very cost effective or just effective period. But from the ones that I have seen, they seem to be quite popular and they got quite a few hits, and also they looked very impressive. And so I'm thinking, right, like if we want to emphasize or educate people about the importance of primary care after SCI, or what primary care can do, for people with complications after SCI, etc., I'm wondering if that kind of work could be or method could be used. And I saw the comment from Tori. Sure, I'll copy the link in a moment for you. Yeah.
Yeah, I think that's a great suggestion, Chester, because I'm just actually thinking to one of my hats with McMaster, and trying to disseminate certain information to faculty, and there is evidence that at least for family medicine faculty, that the videos have to be 5 to 7 minutes. Otherwise, they can't even last like the 18 minutes of a TED Talk or whatever. So they have to be very brief videos. But I think that's a good idea that we should look at as a way of a tool to disseminate knowledge, quick knowledge to family docs with, quick links and so on. So yeah, thanks for putting that forward.
It's Colleen. And I apologize, I had to use the loo. I'm over 50, give me a break. Did anyone mention the SCI nuggets?
Yeah, Jamie did mention that.
Okay.
Yeah.
But is there anything you wanted to say further, Colleen? I just mentioned it, briefly kind of at the start as another tool and resource.
Yeah, and that would be, I mean, it's a tool, but I don't know if it would benefit from just a sort of a not a rebrand, but just a reminder somehow. Like there's nothing to direct somebody back to it again to sort of say, hey, think about this. But I don't know how you would do that, but.
Well, there's definitely like good work that's been
Yeah.
behind that you know, in some fashion we should be you know, if not the nuggets themselves, you know, similarly trying to promote best practices into primary care.
I had a similar thought to what Colleen was saying, and just thinking also about John, you know, what you mentioned about enhancing the voice of individuals with SCI, just if they're, because, you know, as Chester said, it may, the work doesn't always resonate initially with clinicians to sign up and join, but just to promote the voice of individuals with SCI through NASCIC, of how individuals with SCI can have a voice, you know, how to somewhat self-advocate, and then have the nuggets as a tool to bring to their doctors to kind of create a bottom-up communication strategy, but maybe make that a bit of a theme in this work. Just a thought.
Yeah, I totally agree, Vanessa. I think that multi-pronged approach, but really trying to engage individuals is really important.
And I think Peter could speak more, but I think through NASCIC, they're providing tools to help individuals really understand, you know, what it's like to promote or advocate and share, and John Shepherd too as well. But I think that would be very helpful, because in our experience at Praxis, it's to have individuals with SCI engaged, it's really important to make sure that everyone has the same understanding, the knowledge, and then to have the comfort to go forward and self-advocate. So it's something we're looking to see how we could provide more tools on, but I think NASCIC's doing a lot of great work in this area. We'd be looking to them as the lead.
Yeah, and I think as well, a lot of the advocacy organizations, like whether we talk about SCIO or, you know, down in the States, I guess United Spinal and such like that, are very powerful as well. I mean, and not to be overlooked, you know, even from the regional coordinator point of view, as we have a regional coordinator involved with our mobility clinic, and I can't say how important that has been to the success of our clinic. So maybe kind of relooking at how that can reach other primary care, you know, not forgetting that piece on the ground floor.
Okay, maybe I'm just going to move to the next slide. Okay, so here this, and we've touched on this with, I suppose, some of the discussion before, but how, you know, we have kind of a loose network. How do we engage best with folks generally into this network of people who might be interested in promoting primary and community care for individuals with SCI and their families? And I guess we had some things listed already, such as having summits and webinars and research projects, and, you know, maybe collaborative care initiatives and so on.
If you're a
You know, Joe and Jamie, I always kind of feel that education and engagement, etc., are super important, but it is also really important to even kind of setting the standard to let people know that this is the way to do things. And if you are going to, because honestly, right, when I first started, I always heard, you know, from people, oh, after rehab, we're going to hand over the care to primary care in the community. And I always thought, what does that mean? You know, it meant nothing. It basically meant that people washing their hands off of their patients from rehab hospital. That's all it meant. And so if we actually set the standard right, this is what primary care does, and this is how we have to collaborate with primary care, and this is what the expectations are. I think that's actually one way to engage people, so they know that this is the way to do things. If you do not do it, you are not doing your job. just simply by saying that, I'm going to forward all of the paperwork to primary care, that is my job done. That's not acceptable. And so I think that in terms of thinking about education, engagement, etc., those are important. But without the actual standard of how things should be done, people can still do whatever they want. Well, they can still do whatever they want. But with a standard there, if they don't do it, there's some accountability issue there.
So would one of the ways to engage the members of this network is trying to establish a national standard for primary and community care?
I think so. I think it goes back to the age-old question of what is the standard of care for spinal cord injury, because I think that the only thing that I know there are clinical practice guidelines, etc. They're just guidelines, but and accreditation, has some standards up to some extent. But the only thing that was really suggesting how care should be done was like that really, really old white paper, right, from Asia, from decades ago. But then, of late, and in Canada, I'm not sure that there is actually such a thing. And I think that, if we could even just think about, again, the bigger picture, what the standard of care should look like, and then take it from there. That's not the only method. I'm just saying that, apart from thinking about how to engage people, I think there should also be a standard that actually, makes people think that they should be part of it.
Yeah, I think that's a good suggestion. I mean, because people don't want to talk about nothing. I mean, they want to, so this would be a tangible outcome of the network, is to help set a standard. And so that people would know. Any other thoughts? Okay, so if we set up a steering committee, and we have the 2 pizza rule, and we have 12 or 16 people, are there suggestions on the frequency of meetings? How long for? Because people would ask. People would say, you want to meet every 3 months, every month, 3 years, 5 years, life sentence? So do people have some thoughts to share with us, as we develop this and invite people to this?
Joe and Jamie, my suggestion is maybe if there are some specific short-term and longer-term goals, and so those will guide, the group on the frequency of the meeting, because I think that if, one short-term goal is to establish or achieve this within year 1, and people all feel that that's a really good goal, I think that they'll be more likely to say, yes, let's do that. And even if you have to meet monthly, they may just say yes if they feel that that's actually, really a good goal to attain. And so I would like to suggest that perhaps that's more driven by the specific goals.
Yeah, I guess we could always say that, because people would be wanting a general sense, that we could say, it's perhaps every 1 to 3 months, depending on the, what's on the agenda. We'd be starting at this frequency, and we're asking for 3-year commitment. Although if you can't, let us know. I mean, is that this sort of framework that would work? Or a couple nods there. Any thoughts otherwise? Or
It's Tori speaking. I guess I have a question just for the sake of argument. If the goal was to develop a standard, I haven't done that before. I don't have a sense of how long that would take. Would that be, and I'm actually also not sure about jurisdiction. Like, so where does a standard of care typically come down from?
Yeah, well, that's a good question.
Maybe that would take us past our time today. Just
yeah,
like,
there's not like a magical thing. Um, and to develop a national standard, I would say that, it would probably take us 12 to 18 months, quite
okay.
frankly. If I'm thinking I'm not thinking a whole lot about it, but just in thinking what we probably have to do, we could have drafts probably quickly.
But then you have to get a bunch of feedback, presumably, socialize it widely.
There'd be a bit of a process, yes.
Well, then what about 2 years?
Could be 2 years.
Or maybe, Joe, you can break it down into small chunks, right? Because, for instance, obviously primary care is a big area. And so I'm just, giving an example as to how one may break it down. So for instance, maybe the first standard to look at is how do you actually transition people from rehab back to primary care, after the initial hospital stay. Just one suggestion, right? Because that would be quite specific and quite achievable, as opposed to looking at the whole big thing, which may just be so overwhelming.
Yeah, that might be a good point, Chester. And some of these things may be establishing sort of best practice first, or re-looking at what the best practices are from either the committee or the conference that did that, or other publications, and then working them in, and also finding out who's involved in these types of things. For example, in that one, there's probably been a number of people who've done similar projects. I know Heather Fladden at Toronto Rehab has done similar. So yeah, I think you definitely have to pick and choose initially.
Yeah.
Might also help to think if you're looking for an advisory group, and there may be working groups that could look on a standard development separate for the steering committee, or if you see the steering committee having some very clear set priorities to get, as I guess Chester said, building it up, and then the steering committee would be hands-on for those priorities. It would be, just wasn't clear kind of what model you had in mind.
Yeah,
it may depend on the people.
That's a good reminder, Vanessa. I think what we're envisioning is the steering committee is really looking at it from the 30,000-foot view and trying to set, generally what's the network about and so on. And from the steering committee, people from the network would then form working groups, to work specifically on, this research project or that education thing or this activity or whatever. So even things like a national or a standard for, say, its transition from rehab to community, that could be a working group as opposed to the work of the committee itself, the steering committee. But the steering committee would help to prioritize, to say, yes, this is a working group we should have. And yes, we should be, emphasizing having a summit, next year, or those are the high level things that the steering committee would really be looking at, and then ideally it would be delegating to working groups to actuate, what are set as the priorities. If that makes sense.
Yeah.
Okay. I think that's a bit redundant. So maybe I'll just even say, so we would see the relationship between the steering committee and the network. Well, the steering committee would be a representative of the network, which would provide the leadership to it of prioritization and then go back to the network to check, you know, periodically if it's on base of the priority setting, and to establish the relevance and validity of what the network's doing. The other question is though, how would the network, because the network would be lots of different stakeholders in different positions, how can they engage with the greater community too? And is there a thought there? Because there's lots of connections that people have.
I think if the steering committee are wearing those multiple hats, then as the steering committee are then doing those other roles, whether it be with Asia or the Ontario Consortium, then is always bringing the primary care updates to those meetings, or embedding updates from the primary care network into the, for example, the consortium newsletter or into the Asia's newsletter. That might be a way to see how to link and embed as much as possible to spread, or to Praxis and ONF as other examples. And then I think Charlene mentioned there may be opportunities, and I know Joe and Jimmy, you've attended ISCOS, but to then through James Middleton and that he's on other ISCOS committees, and then reach out to him to spread within ISCOS if that's to spread internationally. It's like a stakeholder map, really. I guess you could look to see where your steering committee fit within their stakeholders, and then how they can promote and share.
Yeah, I was going to say that it does, you know, it is a bit more specific to even each geographical location too, right? Because how we engage some of the people in the community in Alberta may be different from how it's done in BC, etc. So just like what Vanessa said, may have to map it out on an international and national level and provincial level, who those key stakeholders may be, and then see how that interface may work.
Because I could see, Chester, in your concentric project, your CIHR project, where you're linking the hubs and the spokes. If you are using some of the tools from the primary care, then you can then share that back to the primary care network as demonstration projects. I could see those sort of linkages occurring.
Yeah, and I was also going to, you know, let Jamie and Joe know that actually in Alberta there is now this primary health integration network, which is actually supposed to be a network that tries to link up all of the different primary care groups together within Alberta, recognizing that, you know, in the past there have been so many different groups, right, that are not really linking with each other. And so one potential way is to try to connect with them to see if they feel that this is part of their priorities. And because if they see that this fits into their work, they may support this work. But that's a very specific thing to the province, right? So I imagine there could be different effort and different strategies going on in different provinces.
Yeah, well, that's good to know, and it makes sense. You know, again, I think I could see a steering committee at least setting priorities. So if there's, you know, ways of trying to engage different jurisdictions, you know, with specific methods, because you're right. Even though what's being done in Alberta and BC and Ontario and other provinces are different, there are certain commonalities actually still. 'Cause at the end of the day, it's trying to get better integration and organization among all the sectors, including primary care itself. And so, you know, I think there are general directions and then probably some specific things that can be done, maybe with working groups or whatever. Okay. Okay. Oh, I thought we would just talk about what are some of the top priorities, and oh, we thought we might mention, I don't know if we want to mention Jamie about pressure injury thing or not. Maybe I'll throw it over to Jamie.
I think it might be early for that stuff, Joe. I think because we're still trying to determine membership, and we've gotten a bunch of good information out of this, and things we can take away and sort of fine tune and get back to people on. I think it might be a little early for specifics. I think we've also heard
I would agree.
Yeah, I think we've also heard maybe a few things that have come out today that would be able to carry forward, such things as re-looking at best practices and standards, um, relook at how we engage different populations, whether it be individuals with spinal cord injury and other clinicians. I mean, I've jotted down a lot of notes on that sort of stuff, and we've also looked at data and economic health or economic analysis. So I think when we look at everything, I think there is a few potential priorities that we may move forward. Not saying that those would necessarily be the ones, but once we establish our steering committee and this sort of thing, those might be some to move along with other ideas.
Yeah, I think I'm thinking the same way as you, Jamie. That this has been really helpful with a lot of input from the folks here on how we should move forward with first establishing the steering committee for and a network, and we'll have to take it away and look at redrafting terms of reference, look at with those terms, who might we invite, and kind of go from there. Maybe it would be helpful for us, if people had any specific people that you think would be really helpful for us to consider putting on the steering committee. Maybe just ask you very bluntly to help us. I mean, we have our ideas, but again, we could, Jamie and I are often wrong on a lot of stuff. So would value any thoughts.
So, Joe, could I just say, just back up for one second with respect to the priorities? I just want to sort of amplify, to reiterate what Chester was saying about a standard, and suggest disaggregating that into two separate issues that I think would be tractable. The first issue is the handoff from physiatry and rehab to primary care in the community. I think that's a huge issue, as Chester said, and I think people in rehab would concur. And so putting together some kind of statement on how that handoff should take place, I think could be incredibly helpful. Then the second issue, I think the term of art is shared care. So what is the model for shared care, in particular between primary care and physiatry on an ongoing basis once the handoff has been made? I think those two issues could be sort of articulated, whether it's a standard or not, or just guidance. I think that'd be very, very helpful. So having said that, in priorities, in terms of the people, I would really recommend, the Ann Johnson Health Station or Vibrant Healthcare or whatever they're currently called, and any other colleagues across the country from the world, not the SCI, rather the primary care world, who have expertise in SCI. I know, along with you guys, that's a very small group, but any others who could be brought in, I think would be really helpful to get a sense of the realities in different local situations.
Okay, thanks, John.
That's a good point, John. And we have reached out to those at Vibrant. As I said, I think they were supposed to be on the call today, so something might have happened with that. And some of our other folks who are involved with the primary care network, who are primary care physicians, some of them just couldn't make it today. So being deliberate about, like what you said, having them involved is a good idea. And I really like those ideas about that handoff stuff, like, because we've had conversations about that before, and it's really coming to, you know, as Chester, you put it, it's really coming to that transition point, right? And it's where things break down, and it's, you know, it's the start of that breakdown of things, right? So that really does make so much sense, and we've had so many discussions with people over the years about it, but just maybe haven't gone anywhere. And so I think it really, in doing that, it would be touching base with all those who've done projects who are similar.
I think somebody from Lens, existing Lens, will be helpful because they understand the community piece. Maybe with OHT, I don't know who would be the right person, but somebody who is involved in the transition of people from going from rehab to the community. I don't know, social work, somebody who manages case manager, somebody who has some kind of a holistic picture will be helpful.
Yeah, that's not bad. Somebody that I work with a bit, name is Karen Lumsden. She does a lot of work with home and community. She runs a lot of the home and community care regionally, and is actually very progressive looking at transitioning, because in Ontario there's a big transition about to happen with home and community care. So it's probably a good perspective to have in there.
Joe and Jamie, I know that Rebecca Charbonneau in Calgary, she's also a physiatrist, and she's been working with a student who recently completed a literature review on transitions after spinal cord injury. And so it may be worth, in fact, you know, for my research team, we are inviting Jocelyn to come to give us a presentation on that, and we're hoping to actually convert it into a scoping review. So that could be quite useful, because she's done months of work on that, looking at the literature. So that may be you know, a good starting point. So maybe connecting with Rebecca could be useful.
Right. Sorry, it's Rebecca.
Charbonneau, Charbonneau. If you would like, I can do an introductory email to Rebecca for you guys.
Great. And then Jocelyn is her grad
student.
Yeah.
Yeah, she's actually an undergrad student, but she apparently is amazing and has done some very good work. And they have a project in Calgary looking at that. And so they asked Jocelyn to complete the lit review. And with my project, you know, which is provincial, we're looking at transitions in care, but then knowing that she's done that lit review, we're trying to maybe work with her to even convert that into a proper scoping review. And so since she's going to present to us anyway, I think that she's got some good materials there to share maybe.
Yeah, that's a great suggestion. And maybe not even necessarily for the steering committee, but, you know, even for a working group or something of that nature, because in some capacity anyway, that makes sense to everybody. That would be great.
It's Tori speaking. I'm not seeing Peter on the call anymore, but if you'd like a representative from Spinal Cord Injury Ontario, then we can figure out who would be best suited for that. Not to volunteer one of my colleagues, but I feel like if we're talking transitions, it's probably the regional service coordinator team who see that best, because they help people transition out of rehab and then address different system gaps once they're home across the province. And then also, if there is a working group on knowledge sharing or education, then I'm happy to contribute, either myself or somebody from my team, and we can try to put our weight behind, or help create and or help distribute something that is created.
Great.
We have lots of different channels that we can use.
That's great. And we're down with you volunteering, not just yourself, but other people.
Yeah. Yeah, so I'm happy to follow up with Peter afterwards.
Let him know he's chairing the committee.
I will. I'm sure he'll be delighted.
Joe and Jamie, I'm still thinking that, you know, if it's helpful, still consider someone with data access to look at healthcare utilization, because if you don't do let's say if we are not doing a good handoff, how many people end up being readmitted within what time frame, etc. You know, things like that could be useful to have in terms of data.
Does anybody have a specific suggestion on a contact for that?
Maybe Brian Chan or something. Would he fit the bill? Or
Brian or Susan Jagwell through her work through ICES.
Yeah.
I was also thinking, as you're creating the steering committee, and maybe you've done this, is just looking in the environment, even within Ontario, to what John suggested, looking at the principles of shared care and transitions, what's going with the consortium, their priorities, the strategic planning with SCI Ontario about the P4Free, and just seeing where the low-hanging fruit are to embed some of the work in ongoing work, to almost have as a demonstration project or build into existing work as you get started. And that strategic piece, I think, could get the network up and going and show value. Because I think Kathy in the consortium, she presented earlier today on her data strategy for looking at indicators, and Susan Jagwell's there. So she may, and John, you may know, just building in these readmissions and maybe looking to bring some of that in, that could be helpful, either as a baseline or looking at changes due to the intervention.
that's a good point, Vanessa.
Yeah, and for what it's worth, just to put in a quick shameless plug for my own work, my plug for my PhD is to use the Emerald database. So that's a database of 500,000 patients in Ontario with EMR, primary care EMRs, to look at patterns of care in the SCI population in primary care specifically. So looking out patterns of care around management of things like pressure ulcers and UTIs. And I would certainly welcome any opportunity for my work to be informed by the priorities of people in the field. So, the more I can be led by, this group, the more helpful it will be for me, and hopefully it'll, make for more useful work.
So are you volunteering yourself for the?
I was saying, I think we found our data expert.
With great trepidation, I'll say yes.
We've recorded this, John, just to
You have the lifetime term of reference there.
Maybe
I'm
I'll
happy
ask,
to be involved.
That's great. We're really happy about that. Maybe I'll ask those from Praxis and ONF too. Who do you think from your organizations ought to sit at this type of steering committee? I know you're kind enough to be here today. If you could give comment, that would be great.
Joe, from SCI, it's only me. So either it's me who's oversees the whole organization. From SCI, I'm the person, so I'll be happy to represent as needed.
Okay, you're signed up too.
Yeah, so another thing will be, like, we are looking for people. I think somewhere might have also thought about the resources and how much we can ask people to do. It's challenging for all of us to being on a lot of committees beside our daily jobs at our organizations. So I'm not saying that just for myself, I'm speaking for everybody.
Yeah.
And then from Praxis, it would be really, I guess, looking as you're creating the steering committee, what attributes you're looking for, because I think there are different folks at Praxis that could bring different perspectives. So someone like myself is more on the research clinical side, but we do have Richard Peters, who's our Indigenous liaison, who's working in BC with the Indigenous population and a model of care. So it could be in a spot for the Praxis, if that would be helpful for one of us to, depending again what expertise you're looking, or we could have, if there was a need for Praxis, have one spot, but filled by different people at different times to again bring in the perspectives that you need. And as Tara said, to bring more people to this rather than always the same, you could consider something like that.
Okay, that sounds good. I think we needn't limit it to one seat necessarily, as long as you're willing to share some of the pizza.
So, Jamie, I've always offered that I work actually very closely with our communication team. So if there's ever need for, use of our communication channels to disseminate and share your work, please let me know. I'll always be happy to work with our communication team and further disseminate the opportunities that come or any other sort of tools and materials that you would like to share.
We appreciate that. I think, I think a network like this, we have to leverage partners who have those capabilities. And I would say, again, with, organizations like Praxis and ONF, you have many people who have really quite different hats and different skills. So I don't think it's necessarily either or necessarily limitation. So because somebody with an indigenous lens might be giving us quite a different skill set than somebody else who has a different lens.
And maybe people like John and me live through this day in and day out, and we have gone through the systems. We can bring some of that experience. So it's not we would like to have others, but you will have that experience as well, what we have seen. And me, it is very different what I see in Windsor City and what I see in Toronto. So primary care is very different places, and it has evolved over the years. I have been 7 years, like things have changed over time, what it was.
Yeah, great point, Tara. And you wear multiple hats and give us perspectives in different ways. And John too. Okay. So I feel like we've gotten a lot of really good information and points from our discussion today. As far as the next steps go, I think our team is going to take away, redraft things. We should circle back to this group as well, and start to put out applications for our steering committee and get things up and running. And we'll draft some terms of reference and for the steering committee and for the network itself. Jamie, did you have other thoughts?
No, I just this is really good information for us. We, as I mentioned, we didn't want to come into this with preconceived notions. We want to have a lot of different viewpoints. So this is going to help us to, I think, arrange something meaningful. So just a really big thanks to everybody for sharing their time, and it's so busy with all these meetings, as Tara said, and that. So we're just really, really appreciative. And thank you, Steve, for your story and being a part of it as well. That's mainly what I would say.
Well, you're welcome, Jamie. And if you do need live-in, or what did you call it? People with lived-in, I could volunteer, except I don't really know what a steering committee's job is, so I'm not privileged to knowing that. Or so if you need someone, I would volunteer, because I do have experience leaving rehab in Hamilton, but then I came into mobility clinics, and I was fine with that transition. So I'm well on, I'm being treated well that way.
Steve, I don't think anybody's ever really an expert in these things, and I know.
Okay.
And it's more about the input and your experience, and certainly you're working. You'd be working with me and Joe, who are experts in nothing.
Well, then sign me up. Okay. Thanks, everyone. Very interesting work.
Yeah, well, yeah. Again, thank you, Steve. Your story, sharing your story is not easy, and we really appreciate that. It does help to ground our work, and make it meaningful that we're trying to help people at the end of the day, and help people help themselves too. So. I don't know if anybody had some last thoughts, but I really want to thank everybody for participating in today's discussion. I want to thank our own team as well, who have been taking notes and keep Jamie and me on track with things, because we forget things quite easily. I didn't even register for this this session until I was reminded to do so. Yeah, thank you all. And have a good day.
Thanks, guys.
Thank you for a great session.
Yes, hi, Lindsay.
Thanks.
Thank you, everyone. Bye-bye.
Bye.
Bye.
Right.